I want to point out, and just, again, this vision for this whole conference, this is the 4th year. It's Dr. Tran's vision. Were it not for you and your leadership and your desire to do this for the community, none of this would be happening, so thank you. And I just want to make sure that you guys are aware that the engine behind that makes all this work is Shari Elijah up there in the back in the yellow. And the reason we can give you, even though you're not going to ask for it, your refund is because we have a bunch of great vendors out in the hall, and we appreciate your giving them your time, but they truly make this happen from a financial standpoint. And Debbie Morales is the one who makes all that happen. So thank you, Debbie. So I'm just going to make this short and sweet. Kathleen Kerr is a healthcare consultant based in the Bay Area. She knows a lot about palliative care. If you've ever seen or heard of the palliative care in California map, where you can actually see where it's offered and where it's not and the disparity that exists, she was the driving force behind that. And Steve Franey is, as you know, the partner with Dr. Fratkin for Resolution Care. He's also, let me make sure I get this right. You're a past chairman and current member of the Circle of Life Award Committee, which is a major award for those dealing in end of life and palliative care. So it's a privilege to have these two experts here with us. They've known each other for a long time, but we asked them to try to put something together for this day, and I look forward to seeing what you've done. Thank you.
Thank you. Can everybody hear me okay? Great. I'm grateful that the question about refunding the conference fee was placed before Steve and I spoke. I hope that your assessment doesn't change. Steve and I, this has been a really inspiring day, and I've enjoyed hearing the perspectives that have been shared so far. I would say that he and I are more institutionalists, where we're going to talk a little more about some practical nuts and bolts issues that have to do with how do you deliver palliative care to hard-to-reach populations, and in particular those in rural areas and those that are accessing care through the safety net. So we believe in the vision and the concepts and the principles that were described earlier, but we also think about wonky issues, and that's kind of what we're going to be focusing on. So, and we also, when we asked about what the focus of this day would be, it was on palliative care, getting palliative care to hard-to-reach populations. That's what we titled our talk. So we have no relevant financial disclosures. Learning objectives, what we're hoping to go through today. So appreciate similarities and differences across seriously ill populations, and hopefully get to thinking about what do these folks all have in common, and what are some of the distinct features of delivering palliative care, in particular in rural and safety net areas. Appreciating the need for stakeholder alignment. So who are the folks who all need to be on board if you're going to be delivering palliative care to particular groups? Understand how the availability of supporting entities, community resources, and payer requirements can impact the type of care that you're able to deliver. Get into some particular challenges with delivering care in these environments, and then talk about some strategies for addressing those challenges. So that's what we hope to go through. What informs our perceptions? Well, we bring to this, or I'll talk about what informs my perceptions. I am not a clinician. I come to this work from an analyst perspective, having worked at UCSF Health System for many years, and then going into my private practice. I've been involved in multiple statewide collaboratives that have focused on increasing access to palliative care, generally through payer-provider partnerships in rural areas and in the safety net population, looking at issues around standards of care as well, and then how to sort of reduce the variation that exists out there in the palliative care world. So while I have a great appreciation for research and what science can tell us about what's going on, my perspective is very much anchored in the experiences of those that I've worked with. And Steve, you want to talk about where you're coming from?
So my experience is from a variety of places. I was formerly one of the 8 housing projects for those at end of life who didn't have a home and didn't have caregivers, and was the executive director of Martha and Mary Ministries in Portland, Oregon, which appears to be like Joshua's house. With Michael, I helped design and implement the work that we're doing in home-based palliative care at Resolution Care. And I also have been an advisor to my former employer, which was the Providence Health System, around the delivery of palliative care, both inpatient and outpatient, across the state of Oregon. As Jay mentioned, I've been involved with the Circle of Life Award Committee from its beginning, which has been a great privilege, and given Kathleen and I both the opportunity to see where the quality and innovation is going in end-of-life care across this country. So that informs my thoughts and my perceptions. And lastly, you can never learn too much in trying to create partnerships and contracts with payers and referrers and providers, and that greatly informs what I've learned over time. So that's the perceptions that I have.
Excellent.
So we wanted to, for Kathleen and I, all rural and all safety net populations aren't the same. And there are a lot of similarities that exist in the rural environment. I come from a rural environment. I grew up on 180 acres of English walnuts in between Visalia and Exeter in California in the San Joaquin Valley. We were more than an eighth of a mile in on off the paved road, on our gravel road into our ranch. And I married a woman who grew up in an even smaller place than I did in rural Missouri, where with the bank, the tavern, and the church, the saving grace was the stop sign that you had to negotiate to get through St. Elizabeth, Missouri. And I had the opportunity actually for a year after I finished my MBA to actually run that farm while my father-in-law had various surgeries. So what I know about rural and the things that we're missing in the rural environment are really things that I truly know. And what I would tell you that I've learned over time is that in the rural environment, even though there may be a lack of primary care and subspecialty resources, people may be greatly dispersed and hard to reach. Oftentimes there isn't a communication infrastructure. An example of that would be in central Missouri when I met my wife in 1977. They were still on a party line. You got them with two longs and a short. And everybody on their road, which was a series of aunts and uncles, could listen in anytime they wanted to about what your business was. And it wasn't until 5 years ago that they actually had internet service on the farm. And so we think that we've got this global connected universe, but in rural America, the meter pole is out there, and you gotta go fix it when you lose power, and that's the way things are. And so, what I know is that community is built in rural environments by fixing and sharing equipment, by helping your neighbor harvest their crops. It's the twice yearly community picnics, the barbecue in the summer, the sausage dinner in the winter. It's the quilting circles that happen in the neighborhood being potentially miles of space. And it's that way that rural populations connect and care for each other. So you might say, okay, well, if that's rural and these are deficits, what does safety net look like? And I would describe it as the social infrastructure that's in the rural community is there, and it's a fabric, and it works. But what happens to a safety net population who purposefully, maybe many years before, decided to get off the grid, and all of a sudden then has health issues? They don't have that fabric in which to build upon. They may have distanced themselves from their family, as David talked about, with the homeless part of the population, often have chemical dependency issues, and that combined with mental health issues makes them very, very alone, very not supported in the way that you can be supported in a rural environment. And so what I see is that while there are many similarities between a rural and a safety net population, if you go to the next slide, what gets exacerbated is this lack of fabric then when you're trying to serve a safety net population on top of the deficits that exist in a rural community. And so David pointed out, I mean, there's a lack of regular medical care, the gaps in the social determinants of health, whether that's homelessness, food insufficiency, transportation, are real. And we face them every day in Northern California. And so what I described to you in the way that I grew up and the way that my wife grew up, these were agriculturally based economies. And they worked really well because everybody was in the same economy. In Northern California, where we work and Michael lives, there isn't an economy, and the economy that exists is largely illegal. I guess that's putting it nicely. And so the same set of resources just aren't there. And that's what makes the difference. So next slide. So the takeaway for me is that you really have to understand the environment that you're working in and the population that you're trying to serve and what their fabric is in relationship to what might be a only modest amount of community resources that can help them. And in that regard, we're experimenting at Resolution Care with a variety of different delivery models. And one of those delivery models is a pure virtual palliative care, home-based palliative care program, where we're only connecting to our population through telehealth and video conferencing directly. And I guess what I've learned that I would share with you is I'm not sure that model can actually work for a whole population, because we need to be able to know what the community resources are. We need to be able to understand the fabric and how it works. So an example, we recently were featured in a Washington Post article on December 15th. And it was about two families in Hoopa, which is very rural. And Michael, I think it's an largely Indian reservation or population. And so these two brother-in-laws, roughly of the same age, with the same diagnosis, COPD, who, in addition then to the issue of the fabric and how the resources are available, then got further separated with the same disease by their insurance coverage. And one of these brother-in-laws had a palliative care benefit and the other didn't. And the difference in terms of how we as Resolution Care were able to support the patient and the family was very different. And the article was about how palliative care saves money, and it's true, it does, but it really shows that there are issues in the way that we're proceeding ahead in making palliative care available.
So taking that as background, so thinking about you have the seriously ill population, and if you break that into sort of everybody or sort of the usual group, so maybe the group that you would think of as receiving hospice care typically, or even home-based palliative care typically, what's driving some of the most recent literature? Say somebody that's in a Medicare Advantage plan who's 82 years old and has multiple comorbidities. That population has a certain set of characteristics. And then you have the rural population and the safety net population. And there's some areas of similarity and there's some areas of difference. One of the ways that you can tease out those areas of similarity and difference is to think about these four stakeholder groups. So you have patients, families, caregivers, referring providers, so those primary care doctors and specialists that are responsible for the disease-directed treatments, the palliative care providers, so the specialty services that'll be taking care of these folks, and then the payers, so the entities that are funding coverage. And you need to have a certain level of buy-in across all four of these groups if you want to get to the point where you can actually deliver services to a particular individual in a particular region. Taking the example that Steve just gave, you can have two gentlemen with the same disease living in the same area, but the difference for them was a difference in healthcare coverage. You could also have that breakdown happen if there's no specialty palliative care in a particular area. So you get into a little bit of a chicken and egg scenario, but the point is you can't just have clinical services available. There has to be clinical services available where there's a funding source for those services. Even if you have a clinical service that's available and there's a funding source for it, you have to have referring providers, primary care physicians, hospitalists, specialty providers that know that that service exists and is willing to refer to it. And then beyond that, and this I think is a particular issue in the safety net population, you have to have patients and families that are willing to accept the service. It has to be acceptable to them. And so you need to think about raising all four of these boats in any particular region for any particular population if you really want to make inroads into increasing access to palliative care. So let's think about the prerequisites for effective interactions across those four groups and talk about each of these in turn. So beginning with information. So patients and families and caregivers, as a starting point, they need to know what palliative care is. How many people have encountered patients and families that do not know the difference between palliative care and hospice? Pretty much everyone. So that is really an important information point that has to be available to the folks that you're looking to serve. And then if they do, for example, have Partnership Health Plan as the entity that's providing their health insurance coverage, they're going to need to know that that benefit exists and then what they need to do in order to access it. Referring providers, and with a nod to any referring providers who are in the room, amongst you palliative care specialists, how many of you have encountered referring providers that do not know the difference between palliative care and hospice? Almost as many as there are who've seen it amongst patients. It's a very common point of confusion. And so referring providers need to know what this is and what it isn't, and the extent to which it's not going to interfere with and will in fact support the other things that they're looking to do. Palliative care providers, what information do they need? Well, one of the most important bits of information they need is, where do I find the patients? I think that the phenomenon that we saw generally in the field when inpatient palliative care services were being developed is, if you build it, they will come. You will develop a big enough patient pool relatively quickly in your inpatient service. That has not been the case predominantly, not exclusively, but predominantly on the outpatient side. So these specialty providers, these hospices that have developed palliative care services, very often one of their biggest struggles is getting enough volume to sustain their program. And then payers, they need to know, well, who's in the region, who I can contract with if I want to deliver palliative care. I heard Tori Fields from Blue Shield of California describe this at a conference once. Her organization was one of the early adopters of having a palliative care benefit for all of their insured populations across all business lines. And she was marching through the state of California trying to find folks to work with. And she said, well, I feel like Santa, but I don't know which ones are the nice houses. She didn't know where she could find entities that would deliver palliative care. And also, I think payers need some guidance and help in figuring out, and this might be in other states more than California, what does good palliative care look like? So we know that we want to offer this to our members, but how can I tell if organization A is doing as much as organization B? This gets at the variation that was described during the lunchtime presentation. So there's a lot of information that folks need. Skills. So amongst referring providers, they need to know how to introduce palliative care to their patients. As Liz said, nobody was bringing this up to her. And I don't think it's necessarily a philosophical stance where I don't believe in palliative care. I don't know that that's where most referring providers are coming from. Maybe many of them just don't have the words. They don't know how to do it or when to do it, and they could use some guidance there. Palliative care providers, they need lots of skills: how to deliver good palliative care, how to introduce palliative care to potential patients, and how to engage with referring providers effectively so that they'll be accepting of these services that the palliative care organization wants to deliver to patients and families. And then all sorts of issues around operational maturity, like how to negotiate a contract and how to manage a contract and how to submit bills and actually get paid for your work. There's a lot to learn there by any organization that wants to get into this very important business of delivering palliative care. And then payers, they also need to have an understanding of being able to engage with patients and referring providers on this. Many payers also didn't have the words or still don't have the words of how to describe this benefit to their members in a way that will be acceptable, and then how to pull in the relationships that they have with potential referring providers to promote use of this important benefit. Okay, we talked about information and skills. Trust. This is really one of the most important things. So patients and families need to trust in the entity that is being offered, that is offering services to them. Particularly if this isn't a group that's affiliated with the medical group or the physician or the health system that they've been working with. Who are you people? I don't know anything about you. Referring providers need to trust that not only palliative care will help, but that particular organization is going to take good care of their patient. Palliative care providers need to trust in the payers. As I heard one payer describe it, we're not trying to kill you. That the amount of money being offered is actually their estimate of what they can afford, and that they're not really going to be asking for the moon and then giving you a buck for it. That there's going to be fairness and equity there. And then the payers need to trust in the palliative care providers. And this is in particular if they're going away from a fee-for-service environment where you go deliver the service, you give us proof that you delivered the service, send us a bill and we'll pay you. If this is set up as a per-enrolled member, per-month payment, there has to be a certain amount of trust that you're delivering the right amount of service and you're meeting the needs of the patient. Okay, time. Time is huge. And it's really one of the biggest impediments to generating referrals, in particular for referring providers. They don't have a ton of time with patients. They have a ton of things they're looking to go over. It may be that palliative care hasn't been brought up, not because they don't know that it needs to be, but it's taking a back seat to talking about chemo options or something else. So referring providers are asked to do so much, asking them to make a little more time to have a goals of care conversation or a prognosis conversation that would open the door to talking about palliative care. That can be a real impediment, and figuring out how to manage time is really important. Palliative care providers, they also have time issues. They need the time to deliver the care that these patients and families need. And when you're in a rural setting where getting to people is a huge investment of time, that can really influence the sustainability of your program if you're spending a lot of time in a car. And payers need time as well. It can be a really big investment in building out a program, developing staff, hiring staff, creating relationships with new vendors, promoting use of that program, and then all the operational ends of it as well. It's a pretty significant investment, and you need the time to do that. Okay, rationale. This is by far the most important one. If payers and patients and families and referring providers and palliative care providers need to get involved in addressing the needs of seriously ill people through specialty services, everybody needs to have a reason to do it. So for patients and families and caregivers, it's why will this help me or help my loved one? They need to understand why. For referring providers, they really need to understand, how will this help me and how will it help my patient? And paying attention to the how will it help me is really, really important. Palliative care providers, they need to have a rationale for doing it in terms of, this is a sustainable business line. This is not going to eat the heart out of my existing hospice service if I start to do this. And payers need to have a rationale, and really in terms of believing that they can offer this benefit in a way where care is improved and costs are either held level or that the fiscal outcomes are positive. Wow, is this still me?
Yep.
Oh, wow, okay, all righty. Okay, so those are the things that you need to get in place. And we wanted to talk about some of the challenges that can interfere with anybody getting to those prerequisites that need to be there in order to deliver specialty palliative care to a particular population in a particular region. And there's a whole huge list of challenges. We did not want to crush your spirit, so we're not going to go through all of them. I'm going to start by going through 4 really important ones: identifying patients, engaging with patients, engaging with referring providers, and then creating balance across services and efforts and payments and outcomes. So we'll talk about these briefly. So challenges. Identifying patients. There's multiple mechanisms for delivering serious illness care. There's primary palliative care, so the work that an oncologist or a primary care physician would do in clarifying goals and identifying surrogates and just what you would expect any good provider to be able to do. So you have primary palliative care, you have advanced illness management programs, you have complex care management programs, you have specialty palliative care offered in hospitals and in clinics and in home-based programs, and you have hospices. Now, hospice is very standardized. In part of the, I do appreciate the variation that was pointed out at lunch, but at least it's a very well-defined set of benefits that have to be made available. And you can do those in different ways, and you can offer things above that, but at least there's regulations there. None of these other ways of delivering palliative care, of delivering serious illness care, are standardized. And because of that, there's huge variation in the way that the target population is defined, and therefore a lot of variation in the way that you go about finding these patients. And that can turn out to be a really big problem. So if you take as an example the palliative care benefit as defined in SB 1004, the California law that mandates that all individuals who are beneficiaries who have received Medi-Cal through a Medi-Cal managed care plan, they have to have access to palliative care if they have certain conditions and certain diseases and meet some other certain conditions. How many of you are familiar with SB 1004? Woohoo, very good, okay. So SB 1004 is available to folks who have COPD, cancer, CHF, and liver disease. And there's 3 sets of main criteria. You have to have one of those qualifying diagnoses, but then you have to have these other things going on that show that you have advanced disease. And then there's also a set of requirements related to the patient and the family. You have to be willing to engage in advanced care planning, and you have to be willing to have a trial of home-based care instead of just calling 911 if you have a problem. You can imagine that with those different types of criteria, they don't exist in a single source. So you can certainly look at claims data if you're the health plan and say, okay, these are all the folks that have these diseases, but you may or may not have information there that tells you these people have advanced disease and that disease is advanced enough to qualify for the benefit. And there's certainly nothing that's going to be available in an electronic health record that's going to tell you they're willing to engage in advanced care planning and they're willing to try out home-based care. And that means that there's usually some hybrid that's necessary, some combined approach that can be very labor-intensive just to find the patients who would benefit. There's also issues around, even when you find patients, them not being interested in accessing the service. And this is from a survey that we conducted with, I think it was 13 health plans and 16 provider organizations around their experiences in offering SB 1004 to eligible patients. And it gets at some of the most common reasons that were identified of why patients and families declined services. So, they didn't see the benefit. They didn't want people coming into their home. And in a safety net population in particular, this can feel really risky if you're worried that there's going to be some witnessing of potentially illegal or activity. Unwilling to do advanced care planning, unfamiliar with the palliative care organization. I don't know who you are. I don't want you coming into my home. And then concern about limiting other services. So wait, so you're going to send me this team in to support me? Why am I not going to be be able to access some other stuff. So there's a lot of trust issues with patients that has to do with effect that gets in the way of effectively engaging with them. So this is a lament from a palliative care provider, a quote that came from the survey. The amount of time cold calling patients takes, usually a call made by a clinician who can also obtain medical history, enough to determine eligibility. All of this time, 1 to 2 hours per patient, might be completely unreimbursed if the patient or the primary care provider declines involvement in the program. The marketing outreach overhead right now is cost prohibitive to trying to build the program. So just finding patients, the effort involved in that right there can be a non-starter from a sustainability perspective. Engaging with referring providers is another big barrier, and these again are some of the observations of the folks who we've worked with in implementing SB 1004. Providers were also concerned that there would be a treatment limitation, that if I refer my patient to this palliative care program, they're just going to use this as an excuse to get them right away enrolled in hospice, and I'm going to lose control over the relationship. And that links right into a misunderstanding of palliative care, and generally that was a confusion of palliative care with hospice. Inefficiency of materials that were or lack of efficacy in the materials that were used to market the program to providers. It felt like we weren't really getting across the heart of the program and what it could do. And then also just that providers are hard to reach. Even if you have the health plan and the palliative care providers doing outreach, trying to engage folks, it can be hard to get on their calendars, to get their attention. Barriers, so just summarizing barriers in reaching referring providers. Time is a huge one, a lack of understanding of what palliative care is, fear of having their cases taken over, and so on. And finally, in terms of a challenge, is this balance that's needed to achieve sustainability. And I can't say enough how important it is for somebody who's looking to create or expand a program to think about the interplay of these three factors. So one is the scope of the service and the effort. You can identify a huge number of needs that these patients have, but those need to be defined into this is what we are doing. And that this is what we are doing needs to line up with the payment amount. You could theoretically do 20 hours a day of care for people, but if you're only being paid enough to cover 1 hour, that's going to be a problem. And then in terms of the payment amount, that also has to be justified by the outcomes of the program. So the amount of money that a health plan or a medical group is going to put into that payment needs to be justified by an improvement in the quality of care or a reduction in the use of other services so that it's fiscally sustainable. So you need to have alignment across all three of these areas in order to make the program work. And that can be a lot of trial and error getting to that point. Even if you start out balanced, balance can be lost over time as the patient population changes or as the services that you offer change. So those are some of the challenges. And Steve, I'll let you, let me give you a quick example here of what I mean by that, in particular of how this issue of challenge relates to dealing with a safety net population. So if you think about the typical focus of palliative care, you have the patient and the family in the middle, and the circles around the outside. Those are the domains of focus for your palliative care team. So you have symptom management. You're offering information about prognosis and care options, assessing values and translating those into medical orders. You're offering spiritual support, and you're offering psychosocial support. You're seeing what does this patient and this family need in order to cope. That is what typical palliative care can look at. Now, translate that into palliative care for a safety net population. And that green circle that talks about psychosocial supports explodes. It's not just, this is really upsetting, we need help in managing this. You have mental health care issues, companionship issues, caregiver issues, access to food, access to transportation, housing and physical safety, and on and on and on. And this will change the composition of the team and the focus of services and the amount of time that it takes to deliver care. That's going to change your scope of service. That's going to change how much it costs you to deliver care, which should change the amount of payment that's made, and it should also change the perspective through which outcomes are viewed. So this is just one way of thinking about how delivering palliative care to a safety net population with intense psychosocial needs can really change the whole picture of what palliative care looks like and what it takes to sustain it.
So go back one, please. So as Michael said earlier, at Resolution Care, we take care of people. We don't take care of patients. And what that can mean is if you've seen one, you've seen one. But I think in practical reality for the pencil-pushing Excel spreadsheet types like me, what that means is that in this particular circumstance with a typical palliative care population and focus, the 80-20 rule applies. So 80% of the care that you deliver is pretty much the same across the whole population. And the 20% relates to if you've seen one, you've seen one, and the idiosyncratic differences that exist in need among patients and families at end of life. But if you go to the next slide and you see this blow up that is potentially meant to be almost bigger than all the other 5 circles that exist there, then it isn't an 80-20 rule anymore, not at all. And in fact, while I can't totally nail this down, I would tell you our experience at Resolution Care is that more than 50% of the care that we provide our patients is non-medical. And the reason it's non-medical is because of the large proportion of safety net patients that we have on service. They represent 75% of our total palliative care benefited population. And we have actually a social work department of 4 people who spend half of those resources are spent on housing alone. So it is important, it is significant, you have to know your population. Next slide. So there are differing levels of care. And as Kathleen talked about it in 3 slides before, you've got to know your population. You've got to understand how you're being paid. You have to understand the expectations of the payers and of the referrers. And then you have to be able to navigate, that's my word, the differences in the requirements that payers have of you. And I fondly hope that someday those requirements will be the same. They aren't now. And some of our payer partners, and I truly think of them as partners, get into our business about how we provide palliative care. They, I think, well, in a managed Medi-Cal population, they have requirements, and I accept that they have requirements. I don't quite accept the fact that they know how to deliver palliative care better than we do in the field. And so there's a little bit of a tussle in that regard. And we have some payers who say, you're the subspecialist, you deliver the care, and try to define for us how you measure quality. And so as a field, Kathleen has already said, we're very unregulated. And as a field, we don't have all of the benchmarks and standards that we're still trying to discover about what quality palliative care is. So that's the state of where we are. And what does that mean on the ground? So I'm a hospital administrator by training, but I've spent 32 of my 40 years in healthcare as a healthcare consultant. And as a hospital administrator, I became very familiar with the notion of wallet biopsies. And that's not something that clinicians should be asked to do or want to do. And so what clinicians prefer in the field is to deliver the same level of care to everyone that they see. And that's difficult to do in the stage that we are in the evolution of palliative care and our relationships with payers. So what are the implications of all of this? An example. So 52.6% of our patients die on service. You might ask why? Because there are no hospices in rural Northern California. And so we feel an obligation, and our payers expect us to walk the journey with our patients, the people we serve, to the end of their life. We have a large proportion of our patients that are homeless. And through some work that we recently did for Partnership Health Plan, we were able to quantify the differences in manpower resource that we expend in caring for the whole population that we serve, and then looking at and breaking out the homeless portion, and then subsequently breaking out the portion that we take to death. And it turns out that that portion of the population that we take to death takes twice as much resource to care for at the end of their life than the average population. And the homeless population, which we classify as intermittently homeless, because if you come on our service and you're homeless, we get you into housing as best we can, and then you get kicked out of housing because of your behaviors. You're not a steady person in the world that landlords want to be involved in. Even if we guarantee the rent, they get kicked out. And so they're intermittently homeless, and they take a huge amount of work. Well, the implication of that is if you only have so much staff, and you have all of these requirements that the payers are putting on you as a substitute for what quality is, and you take the remainder of the time that you have and you focus that on the immediate needs of the patients that you have to serve, and then you've got these two populations, as an example, who are blowing up the needs, who isn't getting care? What happens in that situation when you've got this population that you're caring for? There are a bunch of people who aren't getting care. And so I have great hopes that we will get some additional reimbursement for those populations, and we're talking about it, but that's an example of the implication. There's also, and this is the language of healthcare, so I'm not trying to offend anyone, but there's also a difference in payer mix. And payer mix has something to do with resource consumption and what patients require and what the expectations of the payer are. So we have one payer who says, anybody who's eligible, you will take, and no matter how much of a mess they are, you will care for them. And we have another payer who says to us, you're our safety net. We expect you, when that patient needs your services, to be available 24 hours a day. If they don't need you, that's okay. You just check in with them once a month. And if you can imagine the difference of those two levels of care, you can see that if you're trying to pay attention to burnout and the well-being of your team, you might want to have a payer mix that, if not balancing, had a distribution of those types of patients. And that's a reality. Another piece of this is what I call service capacity. And that is, when you care for people and don't think of them as patients, then you think about doing what they need. And what we've learned over time is we can't do everything that they need. We might like to do everything that we need, but Kathleen's little formula is true. If we do everything that they need all the time, we won't have any staff and we'll be broke.
Awesome.
So we can't do that. So the Good Sisters of Providence taught me no margin, no mission. And that is really true. We're an unusual palliative care provider we are a freestanding palliative care provider that isn't in the hospice business, isn't in the home health business, doesn't have deep pockets anywhere. And so we have to make it on our own every month. And so that determines what it is that we can do at times. And we've struggled, honestly, and we're still struggling, trying to figure out how to put guardrails out there and how to define the resolution standard of care. That is an ongoing challenge for us as an organization, but we're working our way through it, and we're doing it in a way that is consistent with the culture of resolution care, which is we do it as a team. And we make these decisions as a team, and we guide ourselves that way. So everybody has a voice. I will tell you, as an organizational development person, that makes decision-making difficult, but that's what we're currently doing. And then there's the whole thing about payment appropriateness. In my mind, when I look at payment appropriateness, and I'm really worried about Medicare, I think we have to understand the expectations, the availability of existing and community resources in any specific geographic population, the environmental conditions, and what I mean by that is access and density of the population that you're trying to serve, and the population characteristics, which we've outlined before. You have to understand all of those things to do a good job in determining payment appropriateness. And then the provider has to do a good job on the backside of this and saying, look, this is what I'm getting paid to do this service. I can't spend more than I'm getting paid for. I mean, that's the world that we live in. A lot of people will tell you that palliative care is a loss leader. It's a feeder for whatever other business they're doing. I don't believe that it has to be. That's not the way I think about it. Next slide.
Ah, good. So we thought this would be a good point in time now that we've talked about sort of what is the landscape like? Well, what are the things that you need to think about when you're trying to understand the environment in which you're delivering palliative care? And then the challenges that we talked about, the things that can make it rough to engage with patients, identify patients, engage with referring providers, figure out the right services to deliver given the payment that's available. So we are going to torture the introverts in the room and invite you each to turn to a neighbor and spend a couple minutes talking about these two questions. So to what extent are the challenges that we've been talking about similar to those that you have encountered in delivering palliative care or in referring patients to receive palliative care or in paying for palliative care? And then also, what are the things that we didn't talk about that come to mind to you as you think about what makes this kind of tough to do? So pick a neighbor. You're welcome to do dyads or triads or quadrads or whatever you want. And then we'll reconvene you in a few minutes. Okay, one more minute. One more minute. One final profound thought. Okay. All right. So thank you. Thank you, everybody, for engaging in that. I think you all I think you all were very eager to talk to each other, which is nice. Good. So, does anybody want to share something that came up in that little exchange about challenges? Anybody want to share something that came up? Yes, ma'am.
One of the things that we've been discussing, and I discuss with clients all the time, is when they hear the word palliative care and you give a definition of what palliative care is, their brain still is hearing hospice, and they're afraid that means their spouse or loved one is dying, actively dying. And it's a really confusing topic for the person who's providing that 24-hour care. Not in our CFPs, but in the home.
Right.
Most
Yeah.
often.
So it's a misunderstanding of what palliative care is. It's a potentially reading in implications about what it means if I need this sort of support, and it's that whole the skill of the provider in how do I present it to this particular person in a way so that it feels helpful and welcome, as opposed to if I go there, that means I'm going to die or I'm going to lose my other services or yeah. So that's definitely a challenge that we've heard. Thank you. Anybody else want to share anything about it? Yes.
So I know I'm probably preaching to the choir, but as a medical student, and now I'm working in hospitals my third year, I'm working with a lot of physicians who don't know anything about what palliative is.
Shocking.
They know it's even more harmful. They think that it is synonymous with hospice. And so there's this hesitation to refer patients with early stages of CHF or COPD to palliative because we don't want to have that conversation, or they think that palliative is just for end stage. And so it does a disservice to the patients and to my blood pressure. It's like crazy. And so I think, and it's not their fault. Palliative is a relatively new specialty that they weren't educated on in medical school, and they're still not. And so I think starting at the medical school level, and we learn in medical school when to refer to surgery, when to refer to certain subspecialties, but not palliative.
Yeah.
And so I think raising awareness at that earlier level will help later on.
Well, I want you to have really positive blood pressure numbers forever. So, preventing hypertension in you is what's going to be driving. Yeah, I agree. It is a really common challenge. It's that difficulty of getting rid of misperceptions about what palliative care is, and that's a really complicated thing for our peer providers that we're expecting to refer. And there's a lot of different strategies that have been used in different settings to try to overcome that. There's some interesting research that's happening right now. Susan Nguinamos, I apologize if I'm mispronouncing her last name. Susan E. from Keck USC she received some funding to do a bit of qualitative research amongst referring providers to try to get at the heart of this issue of like, well, why aren't you referring, or what comes up for you when you refer? Did you have a bad experience? Of really trying to get at this in a way where we can all hypothesize about why they haven't been referring. But let's hear a little more from them about why it's not happening. And the first round of those findings will be presented at this upcoming meeting in March, where we're bringing together all of the payers and providers in the public hospitals that are involved in delivering SB 1004 palliative care. I think she's going to publish subsequently, but there's a lot of unknown there. But there's also a lot of good examples of how that particular nut, and also the nut for engaging with patients and families, strategies that others have used that have been somewhat effective. And then agree that if they change the medical school curriculum, that will help a lot. It is, to a certain extent, a generational issue. Yeah. All right. Anybody want to admit to talking about something completely different than what we had assigned? Anarchist? Whoa, an anarchist in the room. Excellent. Okay. Find me later. You don't get to share. No, I'm not rewarding that. No. Come talk to us privately instead afterwards. Okay, Steve, let's talk about strategies to address these challenges that we've identified.
So it turns out that there's a difference in how you decide to provide palliative care. And the distinction that I would make cuts across two different components. One is, are you going to provide home-based palliative care by providing the services with staff that live in the geographic region, versus are you going to provide home-based palliative services using what I call remote staff or network staff that can live anywhere, that can provide service with their pajama bottoms on the bottom and whatever suit or tie or whatever starch white shirt they want to use on the top. And then the other distinction is, are you a community-based provider, which connects then to having resources on the ground and committing to serve your community by providing palliative care? Or are you in a channeled relationship? And a channeled relationship is a relationship that we would have with a particular payer, and we're only serving their members. And we're not serving the community. We may not physically be in the community, and we're using telehealth and video conferencing to connect with that population. And the reason I say that that's important is it makes a difference in building the right team. And it turns out that when you're trying to recruit to Northern California, Eureka, Mendocino, what you ideally want in staff is you want them to have all end-of-life experience. You want them to have experience in the home, because working in the home is different than working in the hospital. Really big difference. And you want them PC certified by discipline. Well, guess what? You can't get that. And so you have to be creative, and you have to find people who have one, hopefully, or two of those qualifications. And then you have to spend a lot of time in orienting and training them. And I think that values and culture fit are the thing that I'm always looking for when I'm looking at potential candidates. And we're looking for things like vulnerability, genuineness, non-judgmental, and passionate individuals about end-of-life care, who are great listeners, who are patient. Those are the kinds of qualities that we're looking for. I will tell you that when we don't get all three of our ideal qualifications for our staff, it could take as much as 6 months for them to feel comfortable in working in the home and in the role. And you have to take that into consideration when you're projecting out how quickly you're going to build your census, because it takes all this time to get people on board and for them to feel confident. We have a nurse who says, I'm a good nurse and I'm a good mom, and I can't tell that I'm a good nurse when I'm working in the home because I don't have the same boundaries I had in the hospital. I don't have the same resources I had when I was in the hospital. I am in people's home and I'm alone. I have to be a really good decision maker. I have to be confident in what I need to do. I have to know what I don't know and reach out. Those are sometimes, tough to do. We believe that certification is really important. I know as a member of the Circle of Life Award Committee, if I failed to say that, I would be in deep trouble. But what we do is we help our staff become certified in their discipline. And we give them time to do the education. And we pay for the coursework and for sitting for the examinations and all of that, because we believe that certification is important. And then lastly, so if you're going to care for this population and you can care for them with a remote workforce, that's really important knowledge to have, because these three things, end-of-life experience, certification in the discipline, having worked with patients in a home-based setting, I might be able to get those people in San Francisco, and if they're willing to live in San Francisco and have a California license to practice medicine, I can get them to drop in on video conference and care for patients in the home, right? That all works. And I can do that with a network for chaplains, a network for physicians and advanced practice providers. Those all work. I'm not sure I can do that with social work. I mean, you have to sort of know what the difference is. Michael thinks we can. I'm not sure. The jury's out on that. But so that's some of the thoughts about right team. Next slide. So care delivery. You all know what Maslow's hierarchy is. How that plays out for us at Resolution Care, if there's no roof over the patient's head, if there's no food on the table, it doesn't matter what we're doing in the medical care side, it won't be happening, right? And you guys know this, right? This is your lived experience. It's our lived experience too, which is why we're spending more than 50% of our time with our safety net population delivering non-medical care, because we're closing the gaps in the social determinants of health. With regard to knowing and being efficient with resources, what we've learned, and Michael talked about this a little bit, if it isn't about the number of encounters we have with individuals, because it's all about need. It's about what their needs are today. And it's about improving their quality of life and living with how they want to live. That's really important to us. And so we have to use our resources really carefully. And the way that we do that is if you're going to see a patient in person, we've gotten away from sending 2 staff people to do that. We would only send 1 because we have so many patients to serve. This past year, only 58% of the individuals who had a qualified palliative care diagnosis could we get on service on our continuity teams. So everybody looks at that and goes, how could that be? Nobody has that kind of a situation. Well, it can be that way if you're funding the development of your staff off your own margin, and you don't have a big bank pocket that's going to get them recruited and trained over 6 months and make that happen. And so I would tell you that we have a huge Medicare population in some of the areas where we work, that if we had the resources to provide the service, we would. But as Michael said, the reimbursement that we get is 1/3 of what it costs us to provide the care. And you can't make it economically that way, which means we have to set boundaries. And we have to pay attention to community resources, pay attention to the adequacy of caregivers and finding caregivers. And lastly, something that we don't do that I think we should do, and there are some things that you say in public because they're better said that way, is we need volunteers. We need to do what hospices already know how to do, which is to have a very active volunteer program, especially in a rural environment. We need to get the community involved in the things that we're doing in Northern California. In supporting primary palliative care, that's a big deal. We've had some activity with Project Echo. We're one of those kind of providers. And we take advantage of what I call just-in-time education, where our providers get a chance to talk with the referrer about the appropriateness of the referral, talk with referrers about the plan of care, talk with referrers about being comfortable in titrating opioids or whatever the recommendations may be. Those are all opportunities for education and working with the provider community that you have in place. There's the collaborative learning that Project Echo is about, and then there's grand rounds. That would be a way that we can do more education. And lastly, video conferencing is a big deal for us. More than 40% of our patients live more than 75 miles away from us. I will tell you that if you take the same patient and you do an in-home visit with that patient, or you video conference with that patient, the time that is spent on the in-home visit is twice as much as the video conference. And you say, Steve, why is that? 1, drive time, back and forth. 2, it's easier to get off a video conference than it is to get out the door. Having petted the dog, talked about how nice the curtains are, all the things that you all know. So I really highly recommend using video conference, but what we also know is that most of the world of clinicians hasn't been trained that way, and there are some psychological barriers, we'll call them, to getting clinicians comfortable with being present through a screen. And so when you recruit, you have to make sure that people are willing to use video conferencing. And then you have to help them use video conferencing. And sometimes you have to set goals that they will do more video conferencing. So this is something that we really believe in Resolution Care. We are really trying to see how much of this we can use, because I know those people in HOOPA that were in the Washington Post article wouldn't get the kind of services that we could provide if it weren't for video conferencing. Next slide. Kathleen has talked about developing a sustainable referral pipeline. I'm not going to go into that, but just to say it is a huge issue and can be a big spend for palliative care providers trying to get that pipeline to flow. When you're in a community setting, you've got to manage demand. And if you've got to earn your way as you go, there are going to be people that you can't serve because they don't have a palliative care benefit and you can only provide so much uncompensated care. So that's a reality. Balancing payer mix is something I've talked about before. Sometimes you can do that with the different payer partners that you have. And you have to understand that difference, both not only how they pay you, but what the resource consumption actually is. So I will tell you without naming names that in comparing 2 of the 3 payers that we have, there is a 40% difference in resources expended between one of those payers and another payer. And if I know that, I can think about then how to balance out workload to achieve self-care and to achieve a larger census. I think of the work that we do as a scarce resource. I see all of this demand that we can't get to, and I say to myself, how can I be with our team as efficient and effective as possible, serve those patients who could most use palliative care, whose lives we could most impact, and do that without burning out the team. It's yours.
Okay, thank you. So, a few other strategies that some of which came from projects that Resolution Care participated in, others not. So, effective patient identification strategies. Is usually, I think the big take home message here is that it's a hybrid approach that works. There's not one good way to identify the patients who most need palliative care. And typically, you want to have this be undertaken in a way where there's a partnership across groups. So, the health plan or the payer and the palliative care provider organization, and ideally the referring providers, all need to pool their assets to come together to identify the patients who need services. There's a lot of work that's done on the plan side where they do mining of their claims data. So they look at, these are all of our beneficiaries, and we'll use these certain criteria to identify patients who would likely benefit. And then we send that list along to, for example, the palliative care providers to do cold calling, to ask folks, to say, hey, you may be eligible for this. Can I talk to you about it? There's that can work, and it can also be very labor intensive and underwhelming in terms of referral rate. I was speaking with a plan as part of a project recently. They ran this scan that identified patients that had the diseases of interest and identified 40,000 patients. They added to that an indicator of severity of illness, so a risk score, that got it down to a list of 4,500. They sent that list to the palliative care providers that they'd engaged with. And the conversion rate, the proportion of those patients that were found to be eligible was about 10%. And so those providers spent a whole lot of time doing calls to find those patients. Now, in the end, you could say it was a success. They found hundreds of people who needed services who were hooked up with those services, but it's very much a moving target still in terms of what's the right way to identify these patients electronically and then combining that with human effort. So claims data, it also matters who makes the call and how it's conducted in terms of effectively engaging with patients. There's a lot of emphasis on and a lot of success in engaging providers that are in particular hospital-based. So the hospital-based case managers and utilization managers, they're getting these patients at a point of crisis, and they're right there in a captive audience, and it's a pretty easy time to do an assessment, and developing those relationships as a way of identifying patients can be really, really successful. Similarly, working with your referring providers, sending them lists of patients who might be eligible and asking them to scan it, saying, hey, amongst these 20 folks that are on your panel, do any of these folks seem like they need some extra support? Would you like some extra support in taking care of them? And then also having affiliated home health agencies identify patients. Those teams are in the home. They can see what's going on. They may recognize decline or appropriateness before anybody else might. So I think the big take-home message here is a layered approach for identification, and then also working to integrate with other healthcare delivery settings. So you're not just a standalone hospice that's offering palliative care. You're working with inpatient teams. You're working with the home health agency. You're working with the referring providers. Least effective strategies. These are perceptions that were shared by folks who answered our survey who were implementing SB 1004. The plans felt that a very ineffective strategy was just relying on the palliative care teams and the palliative care providers and the specialists to identify patients and then refer. It's like you could go do a lunch and learn and say, hey, this is our program. And it turned out to be that there was, quite a bit of lunching and not a lot of learning that was going on. There was that guy, yeah, it's one more program. So doing that sort of ad hoc education and outreach, not super effective. Sustained contacts, like embedding a palliative care provider into rounds, or somebody who goes to the clinic once a week, or that sort of thing. You need to be there frequently to be visible and keep this top of mind for the providers that you want to identify patients. Cold calling, a quote from a provider organization once they got a list from the health plan. Information is often inaccurate, members are suspicious, lack of medical information, and barriers to obtaining this from the primary care provider. Who wouldn't want to do that? So, I think that it's hard to identify patients without doing a certain amount of claims data mining and a certain amount of cold calling, but don't rely on this as the best method of identifying patients, and don't underestimate the amount of work that it takes. And then just a final observation that was made by people that we asked about this, something that doesn't work in terms of identifying patients is just hanging out a shingle and waiting for folks to show up. You have to do something. This is a coordinated, concentrated effort. It hopefully will get easier over time, but just having a service there doesn't mean that people are going to be identified, and it doesn't mean that they're going to be referred. Let me see here. Actually, the one point I want to make on the bottom here, and you can get this from the slides that it would be, I think they'll be available for download, is really pay attention to this common 4-part approach, which I think seems to be in place for the most effective partnerships. So list generation based on claims data that takes into account diagnosis, and then risk score, and then some evidence of utilization history. Review of admitted patients, really successful. Who got admitted to the hospital yesterday? Does that person have a diagnosis we're interested in? Would they likely benefit? That's a real-time contact with a captive patient who is in crisis and probably needs some extra support, a great way to find eligible patients. And then there's usually an arm of this where you're asking primary care providers and specialists to refer, and then also working with plan case managers, other health plan staff who are not explicitly affiliated with the palliative care program, getting them on board to think about who are the individuals who they're having contact with who might benefit from this service. What works best in engaging patients? So this is the comment that was brought up where you have a lot of confusion about what palliative care is, fears about it. Really face-to-face or at least direct is best. Sending someone an email or a text that says, you may be eligible for palliative care, that's probably not going to resonate with them. And it's really also allowing time to build rapport, to understand what their needs are, and to lead with the information about, well, what is hard for you and your family now? And then explaining to them how palliative care can help with that, instead of getting into a description of this is what palliative care is. It's an interdisciplinary team that offers an extra layer of support, blah, blah, whatever. You know, I need help with this. We can help you with that. We can take the trash cans out. You know, I actually had a team that said that. The way that we got in is for an older couple, we could take the trash cans out to the curb on our way out. That's what they needed, and that built the trust. So it's really about relationships, warm handoffs, provider to provider. So you have the palliative care provider meet the patient in the hospital when they've been identified, or meet the patient in the clinic, leverage the trust that's been created through a relationship with another provider. A consistent case manager contact at the plan. So, you know, you have a patient or a family has a relationship with the case manager that's been built over time. If that person can introduce palliative care, that's a really great way to engage families. And then, as I said, addressing their immediate needs first, and then teaching them how palliative care can help, as opposed to teaching them about palliative care and hoping they can see how it's relevant in their lives. Strategies for engaging with referring providers, again, face-to-face meetings, and really conversations in the setting of specific patients. So not general, not theoretical, not one more thing they have to worry about, but given your panel right now, who could you use some extra support with? And really bringing home the idea of this is how we can help you. We're the eyes and ears at home. We can be there for them when you're not. Oh no, I don't want to give up my 3 a.m. phone call. Okay, sure, you can help with that, no problem. And then also the tried and true strategy of really starting with referring providers with whom you already have a good relationship. So if you're a hospice that's been in the community, you have a new palliative care program, you know people who have been receptive to hospice, who know your organization, work with them first to develop those referral pipelines for patients that they know that they're likely to trust you to offer palliative care. And then Steve and I both talked about this issue of aligning services and payments and costs. The big take-home message here is to don't try to do more than what you can do given the resource that is available to you, and to really set expectations around that. So most folks don't mind that you can't do everything, as long as you're clear about what you will do and then you do it. And it is a slippery slope that is really hard to recover from if you start to provide tons of service, find that you can't afford to keep doing that, and then you either try to retract or try to get more money. I'd also say don't be wedded to any individual model. So if there's a way that you've done things, like for example, palliative care is an interdisciplinary intervention. You need the input of physicians and nurses and social workers and spiritual care professionals, but you should not be wedded to the idea that all those people need to see the patient at the same time in order to deliver an interdisciplinary intervention, because that will be cost prohibitive outside of the hospital. So think in terms of what you can do to maintain quality and the fidelity of your intervention while also introducing efficiencies, in particular through things like video conferencing. So I just want to review very quickly a couple resources, and we're going to review some key points and take a couple questions. So one is these are all free. It's resources and one invitation, and the invitation's free as well. There's a project that was run through the California Healthcare Foundation, the Payer-Provider Partnerships for Palliative Care. It was 6 dyads or more of payers partnered with palliative care providers that came together to design and then implement new community-based palliative care benefits. The findings of this, the lessons learned from this project, have been documented and have been made available, and I think some pretty user-friendly documents. There's 8 topics covered: initial engagement, that is between the payer and the provider, defining the eligible population, promoting appropriate referrals, service design and operational issues, and so on. These are the 8 topics. You can either download a PDF that covers all of them or just pick the topic that's of most interest to you if you're looking to get into this and benefit from the experience of others. This is a great resource. The Palliative Care Quality Network. Is anybody in the room a member of PCQN? Woohoo! Okay, so PCQN, for those of you who are not members, it's a national learning collaborative that's committed to improving the care of seriously ill patients and their families. And it has 3 main components. One is a patient-level registry. This is evolving soon, where they're going to get into a national database, combining with some other services. But for at the moment, and I would assume for the foreseeable future, this would be retained. There's an ability to enter data about the individual patients that you care for that you can then look at to assess your own metrics, your own outcomes, and then also it lets you benchmark against what's been achieved by others. And that's really, really useful. You can feel so siloed in this work if you don't know, well, what does good care look like, or what does efficient care look like? This gives you a chance to do some comparisons and to really hone in on that quality issue. There's also a bunch of resources that were developed over the course of 15 months where in this first year of implementation of SB 1004, we held a series of 5 workshops focused on different topics that were pertinent to the development of the palliative care benefit and the implementation of the services and the interactions between the plans and the providers. Much of this information was driven by the observations of the plans and the providers that were involved in doing this work. There's slide sets, there's worksheets, there's all sorts of stuff. This is in the process of being redesigned to become even more user-friendly. But for right now, if there's a topic that you're wondering about that falls into any of these areas and you're looking to deliver palliative care to a Medi-Cal population, this is a nice resource for you. And then also a document that was developed by the Coalition for Compassionate Care of California in collaboration with Blue Shield of California. There's some consensus standards for the delivery of community-based palliative care. These really identify sort of a basement, sort of a minimum level of service that should be delivered to at least this population. This is what at least palliative care should look like, to try to eliminate, the goal is to eliminate some of that variation that Steve talked about, where if you have 4 partners and 4 different definitions of what palliative care is and 4 sets of expectations, that can be really hard to operationalize and sustain. These standards can give you an example of, well, this is what palliative care could look like, developed by a group of experts. And then finally, this is an invitation. This is the mapping project that was mentioned earlier, where the Center to Advance Palliative Care is looking to document nationally where is non-hospital palliative care available. And so there's a pretty brief and painless set of questions that you'd be asked to answer that would allow you to get your program on the map as an entity that's delivering clinic-based or facility-based or home-based palliative care, to help to get a sense of what it looks like in the nation. And in particular, it would be a shame if there were rural programs or safety net programs that were out there and operating that weren't being recognized in the national pool, because the particular needs of these programs, the first step in being paid attention to is just saying, hey, we exist, and what we do is maybe a little bit different from what you all do. Okay, take-home points. Steve, you want to start us off?
Sure. Just a second. So take-home points. Not all hard-to-reach populations are the same, and we've talked about that. Understand the needs of the specific population, understand regional variations, understand what the fabric in the community looks like. Sustainable access to specialty palliative care requires aligned aims among the 4 stakeholders that Kathleen talked about. Patients and families and caregivers, referring providers, palliative care providers and payers. Key challenges include designing services that offering different levels of care, identifying patients, engaging with referring providers, achieving balance across scope and cost of care, payment, and outcomes. This is a dynamic field. Guess what? We don't know all there is to know. We're still learning. We describe our efforts as redesigning the plane as we're flying it. And if that has some meaning for you, that's where the field is. All challenges have solutions. Kathleen and I want you to leave on a positive note. All challenges require innovation, require testing, require reorganization, and seeing what works. So get on your experimental hat. All solutions probably require more time and resource investment than you expect.
We didn't want you to be positive for too long.
Yeah.
So.
What do they say? Change takes 7 years. Actually, Michael and I talk about this a lot. Sometimes what you might think about doing that I have a little bit of a passion for, not that I'm willing to not go through a change process, but make the best version of yourself the next thing that you scale. So learn all the lessons, all the things that you want to change and the things that you're doing. Put those into place if you can in a new service area and see how it works. And lastly, it truly is worth it. The stories, the successes, they warm your heart.
Excellent. And we just want to have our closing slide be some acknowledgments of all the folks who we've worked with over the years in lots of different ways, whose wisdom and experiences and expertise inform what we were able to share with you. Our contact information is here, and if there's anything we said that was completely upsetting, you're welcome to contact Steve. If there's anything else, you're welcome to contact me too. Happy to share with you any documents that we have or experiences, or even just hear what's going on with you. And we want to thank you for your time. And do we have time for a question or two? Or sure. So, anybody have a question? Feel free. Yes, sir.
With the implementation of SB 1152 that requires hospitals to do a bunch of things when they discharge a homeless patient, have you heard or thought about how that might have an impact on the relationship between the palliative care and the safety net company?
I think it's a great point, and that's the third group that's being invited to this SB 1004 gathering in March. We have all of the managed care plans have been invited, and many have accepted already. All of the known palliative care vendors who we've been able to identify have been invited, and many have accepted already. And we've also invited in all 17 of the public hospital systems across the state to think about how we can make those connections of making it easier for everybody at these transition points across the disease course, and how we can align efforts. So terrific point. Yeah. Okay. All right.
Thank you.
I think we exhausted them. Thanks, everybody.